Hi, this is G.H. Glade for Coaching ADD and the Stimulus-Driven Brain. Today we're going to talk about Adderall, but we'll talk about the class of methamphetamine salts. The first thing to realize is that stimulant medications have been around for in excess of 100 years. And this is continuous clinical use. Why is this? Well, they were the very first antidepressants. And often in my treating people with very treatment-resistant depression, I will use these as an augmentation even when somebody doesn't have ADD. The methamphetamine salts, well, that should perk up your ears. And for those of you who watch the series Breaking Bad, I'm going to refer to that because it provides some really good visual references, aside from being really good writing. Pretty dark, but really good writing. Well, methamphetamine salts are a class that will show up on a tox screen as methamphetamine. And I tell all my clients, if you are ever in the situation where you have to provide a urine sample for urine toxicology, the very first thing you're going to say before you tinkle in the cup is, what is the number my healthcare provider can talk to somebody or fax information in that the presence of this in my urine tox does not represent drug abuse. It's a prescribed medication monitored by my healthcare provider. And people need to tuck that away in the back of their head. For most people, they'll never have a urine tox screen. When I worked for Harborview, the University of Washington, it was in the policy that they could do that at any time. Did I ever see it done? Not in 20 years. But you have to know that. Let's come to the Breaking Bad analogies. You know, this day and age, methamphetamine addiction is an epidemic. In the emergency room, 85% of the psychiatric admissions to the ER where I worked had methamphetamine on board. It is an awful, awful thing. But we have some differences, hence Breaking Bad. Walter White's Blue Ice was so desirable because it was the same every single time. He had consistent process, consistent reagents, and street methamphetamine is not that. It is a rogue molecule because people make it all sorts of different ways. The other analogy, or the other visual from Breaking Bad, is when they were making the big sheets of crystal methamphetamine. They would break it into chunks. Realize that abuse doses are 3 to 10 grams per use. That's 3,000 to 10,000 milligrams. And for therapeutic use, we're topping out at 30 milligrams. So they're vastly different in terms of what people take in. So let's move first to Adderall. Adderall is the most common methamphetamine salt. It comes in a short-acting and a long-acting preparation. Long-acting meds are standard of care because they are less problematic than the short-acting. But the short-acting has their place. Short-acting medications, they go into your system and out fairly quickly. Duration of response is a key factor in this. For short-acting agents, it can be as little as 2 hours, and some people hit nearly 4 hours. They basically go into your system, rise in blood level, and then they come down quickly. And that down regulation can sometimes be problematic. Some people have a crash in mood. Some people have what is called rebound focus issues. You feel more unfocused than what you were at baseline. But they do have their place, and I'll come to that in a bit. Now we come to Adderall. Adderall has 2 beads. And each of the beads are coated with a pH-specific coating. So what happens is you take one, it goes into your large bowel, you get a bell-shaped curve of release, and then that, what's called a bolus, travels on down through the bowel, and the bowels kind of stop-start, so it spreads out. And then you get a second, more drawn-out bell-shaped curve of release. And that's how they accomplish the time release aspect. Now, if we were to take a handful of pennies and just throw them across the room at a specific spot, that would look like a graph for the response median time for Adderall. It's a scattergram. People vary widely. We have different pH profiles through the gut. We have different GI transport times. And the normal GI transport time is 18 to 24 hours. And if you wish to test this, this can be easily accomplished for about $1. It's called a can of corn, for sure. Where is it mouth to finish? And that gives you your GI transport time. And that factor is one of several when we look at the kinetics of Adderall and why some people last almost 9 hours. The short end of that is 5.5 hours, roughly, give or take. Now, we have a dilemma with a managed care environment, and one I actually had to deal with this morning. Many insurance companies, Aetna, Kaiser Permanente, they allow 1 pill per day. And let's say you have a duration of response on the lower end. That ignores the science, because the science is there. It was put out by the original manufacturer, which was Shire, which has since been gobbled up by another big pharma company. But that's the equivalent of, yes, you're nearsighted, but you can only wear your glasses for 6 hours during the workday. The rest of the time, well, tough luck. This is problematic, and here's where short-term medications can come into play. We can use a long-acting medication for most of the response and then layer out the response using short-acting medications. What happens is you mitigate the fast down-regulation of the short-acting when you do this, when you layer on a long-acting, because you still have a little bit of that in your system, and it leaves it so you aren't just dropping out in terms of blood level. The other utility for short-acting medications is money. The difficulty is these medications, even if you have insurance, sometimes they can be expensive, and the longer-acting medications are more expensive than the short-acting medications. I have clients who just don't have the means. They don't have insurance and whatnot, and so for those folks, short-acting is the remedy to that. And yes, you have to take a dose usually 2 or 3 times a day, and some people take up to 4 times a day because they just don't last as long as what a person needs to have focus regulation in. There's another issue with generics. The reality is generics can vary in potency up to 40%. Which is kind of ridiculous. 40% is not a tight margin at all. So one of the things, and this is with all medications, I tell my clients, track what generic you're taking. If it changes and you feel like, gosh, this just isn't working the same way it did, it's probably the generic. I sometimes will specifically prescribe a particular generic medication. So when you have this issue with generics, sometimes it's even the binders that they use in the medication. It's not just the stimulant medication. So let's talk about other medications in the MAS or methamphetamine salt class. Adderall is a 4-salt mix. Its longer acting relative is Vyvanse. Vyvanse is a single salt. It's bonded with an amino acid. We have a duration of response of 12 to 14 hours. It is very smooth. The only downside is sometimes it's a little lengthy on kicking in and getting working. They have come out with a number of medicines in this same class, and they're kind of what I call Me Too drugs. Essentially, it's the same core chemical, the same molecule, but they formulated them differently. There's one that has a 3-stage release. For some people, these work better. Mostly they're more expensive. And again, they're what I call Me Too drugs. The manufacturer has configured them to release differently, so they can charge more money for them. And oftentimes these are hard to get by in terms of the need for prior authorization. Pretty reasonably, an insurance company will ask you to use a generic medication first. That's why Adderall is the most common. It's a long-acting and it's generic. But there's an assortment of other medications out there that I beat off the deluge of pharmacy reps because they're just tough to get authorized, because you actually have to fail a shorter acting medication. And sometimes this is really hard to justify. I will probably do a whole thing on how to get through appeals and prior authorizations. Basically, it's something that every healthcare provider who does this and is conscientious about getting their clients the medications that are useful for them has to endure. So, as I usually say at the end of these videos, it is really helpful to share good information. So most of all, I want you to share. And if you like this content, and believe me, I'm sort of learning, I'm working on production improvement and those sorts of things, go ahead and subscribe. Go ahead, the button's right down there. You can do it right now, and you will get in the feed for more videos. I put out my videos every Monday. I would like you to hit a like, leave a comment. This all helps this channel get established, but most of all, share the information. So this is G.H. Glade for Coaching ADD and the Stimulus-Driven Brain. We'll see you next time. Take care.